Welcome to I Didn't Sign Up for This, a podcast brought to you by Alzheimer's Arkansas. I'm Carolyn, your host. We are going to dive into the complexities and challenges of being a caregiver to someone with Alzheimer's and other forms of dementia. This is just not about the disease. This is about the caregiving experiences, the challenges, the mishaps, the miscommunications, and understanding of how this disease affects families, communities, and our society as a whole. Thank you to Elder Independence Home Care for sponsoring us and underwriting to make this possible, to bring this podcast to the podcast land and you listening. In this episode, I had a chance to speak with Dr. Brian Bell of Arkansas Hospice, an amazing man within himself. We will learn today when to use hospice, how to access the program, and most of all, the many benefits of using hospice home care. Hospice is an amazing program that many people fear. Dr. Bell will give you a unique perspective on the benefits of using hospice for not only the person with the diagnosis, but the family overall. So join us as we speak to Dr. Brian Bell. Thank you again for joining us to this month's podcast, those out there at Podcast Land. We are Alzheimer's Arkansas. We are a nonprofit that provides education, support, and resources to families caring for their loved ones with Alzheimer's, dementia, and other forms of dementia. Today we have a wonderful, I love this man. He does not know how much I love him. He does know. I'll tell you a little story. But I remember when I first came to Alzheimer's Arkansas, and he spoke at one of our caregiver workshop, the way he communicated and educated on Alzheimer's, I just got it. It was so easy for me to understand. His terminology was on the layman's terms, and I just learned so much from you that day. Years later, I've heard him a lot of times. I've heard great things about him. And one day, I have to say this, he saved my life. So when you think about hospice, he laughs because I say this all the time. He saves my life, kind of, but if you know Carolyn, I just do crazy things. I drove up on a rock, and I could not get off the rock. And we're at a networking meeting. He is speaking, and there's a lot of guys there, and he has his suit coat on, and I just say, I need somebody to help me. And out of all the guys there, Dr. Bell takes off his jacket, goes out, gets under my vehicle, and get me off that rock.
Picked it up like this.
So he is a Superman. So, I mean, just to do that shows the type of man he is and always helpful. So I brought him today because we're going to talk about hospice and palliative care, which to so many people is like a bad word.
The H word.
The H word, like the new bad word, like if it was it's the H word. And it's a very difficult thing to communicate with people. And I say I love hospice. I know that's just like a lack of another word, but hospice is a benefit that we should all be aware of. And because I help people with Alzheimer's and dementia, one of the resources I bring up a lot is, have you considered hospice? Tell us a little about yourself, and then talk about hospice as, you know, the H four-letter word.
That's right. So, yeah, I'm Dr. Bell. I'm the Chief Medical Officer for Arkansas Hospice, Arkansas Palliative Care, and our Arkansas Advanced Care. And these are three different programs. Obviously, hospice, you know what that is. Our palliative care programs are for patients that are just maybe not ready for hospice at that point. They may be ready, or they may be too early. We determine, and then our advanced care program is for home primary care. And I have about half of my patients are dementia patients that I take care of at home or in assisted living facilities, memory care units. And so we put a big emphasis on dementia. Even right now, my whole team is going through dementia training, getting dementia certified, because it is such a special disease that I think you really do need, and even I'm going to go through it, because I think you really need specialized learning to learn how to take care of the patient, but more importantly, how to take care of the caregiver and their families, because that's where we get lost, because a lot of times they don't know, that doesn't get translated very well. And even the medical profession as a physician, to take care of caregivers is not something that's taught in medical school.
Yeah, that's an abnormal thing, to take care of the person taking care of the patient.
Yeah, and that's what I love about hospice and palliative care. And what we do is the patient is our patient, but really the whole family or the caregiver is who we take care of. And I'll be honest with you, in dementia specifically, we spend 70% of our time with the caregiver, right? The caregiver is the one that's going through a lot of anxiety. They don't know what to do. They don't know who to call. The patient we do take care of, and this is very much important, but that caregiver, we know that the better that we can take care of a caregiver, the better they're going to get to take care of that patient. And that's important. That is a very important part of what we do.
So just to piggyback off that is, you know that when you take care of the family caregivers, it improves the quality of life for the person with the diagnosis,
Right.
which goes back to the purpose of hospice
Yeah.
in a nutshell, to improve the quality of life. So hospice is a 4-letter word, and people are so afraid that hospice is out here shortening people's lives. So one thing I say, because I don't work for hospice, I can say it is, hospice does not get paid if your person passes away. That's the funeral home,
Yeah.
right? So their job, they are not looking to shorten their lives. In fact, you had a presentation the other day, and you talked about how hospice can give more days to life. Kind of talk about that a little bit.
Yeah, so in hospice in general, I think people are not afraid of hospice. What are they afraid of?
Death.
They're afraid of death. And sometimes hospice becomes synonymous with death. And I think that's where it gets confusing. I think they don't want to face death. And so when hospice comes up, it forces that issue a lot of time. But yeah, it's true. There's studies that have been done, and not so much in dementia, but in a lot of congestive heart failure. You live actually 72 days longer versus patients that are on hospice that are not on hospice. Patients with pancreatic cancer, it's like 30 days longer. So why is that? So why are patients living longer? And I really think that it probably happens with dementia. They just haven't studied it as well.
And you can't really give a
Yeah, it's a little harder of a
gauge,
disease,
yeah.
right? But the reason is because I say this all the time. Hospice is the Cadillac program, right? I mean, there is not a program that's going to come into your house. It's available 24/7. Who pays for things like respite care, 5 days unlimited respite care, so the caregiver can get a break for 5 days and do that on multiple occasions. And then when you call it at Christmas morning at 3 o'clock in the morning, and your patient who's dementia, who's acting weird and acting funny and maybe violent, instead of getting a phone call, because what happens now? You're going to call home health. You're going to call your doctor, and you're going to get a message. If this is an emergency, call 911.
yes.
Duh. We knew that.
Yeah.
But they're going to say at hospice is, I'll be out there in 30 minutes, right?
Yes.
Now, what a relief that is. There's somebody's going to be out there to take care of the situation. You can be back, because I think one of the things that hospice does is it sort of takes care of so many things that a caregiver has to put together. They take care of DME, medications. They take care of all of these things. And then the caregiver can just be a caregiver, or be a, husband or a wife, or a daughter, and still have to be a caregiver. There's still things, hospice is definitely not going to come in there and be there 24/7.
That's
So let me
correct.
be very clear. They're available 24/7, but they're not going to be there 24/7. But just knowing that you can pick up that phone call at any time, and
Somebody's going to answer.
a person's going to
Gonna
answer,
yes.
and then more than likely, if there's an issue, a person's going to come out there to address what's going on, and not just say, "Oh, go to the emergency room." And guess what? The worst place for a dementia patient to be is in the hospital. Or in the emergency room. If you can
Anywhere
keep it-
outside of that home is the worst place to be.
Right,
honest.
and one of the places, and that's, I think, one of the great things that hospice really brings to the table. Yes, it's a fearful word, but I always say, death is not optional, right?
It's not.
But the quality of life that you can provide for someone, there is options
There
there.
is an option.
And I think caregivers need to know that, yes, we're not going to stave off death. That's not going to happen. But from this moment to death, what do we do? What options do we have? Can we provide a better quality of life? And I definitely believe that hospice and palliative care can definitely be a part of that solution for a better quality of life for patients. And right, there may be at times where, because of some of the interventions hospice is doing, patients may live long. And I give examples, all the time. If you're in that home and a nurse is in there, and and the patient starts coughing or something like that, and what do you do? Like, I mean, I'm the same way. I don't go to the doctor till I'm like nearly dead, right? Well, if that nurse comes in there once a week and listens to their lungs, like, that sounds like pneumonia. Let's go ahead and get some antibiotics started today. And I think there's a lot of misconceptions about that.
Yes.
Right, like, they're going to take all these medicines away. We're not. I mean, we may add some. Yeah, there may be things we take away, but to be honest with you, America in general, like with dementia patients, have a problem with polypharmacy, too many medications. And so the idea is to go in and take some medicines away so that we don't, get too many medicines on board, which could actually have a life expectancy issue. So, but yeah, we want to, we can treat things, be a little bit more proactive because we have eyes in there all the time, whether we have a CNA in there giving a bath and they notice a rash or they'll notice things. We can be very much more proactive, and so if you wait 2 weeks to treat pneumonia, it may be too late at that point.
It may be too late,
and
yes.
Now you're in the hospital, and now you die. So yeah.
Yeah, and the one thing, so when you talk about I also suggest people, maybe your loved one is in a nursing home, a long skilled facility. So hospice will come there and still provide the services, and they are that extra set of eyes. They are biased to whatever is going on in your facility, and that's an important factor outside of the home that people don't recognize to use hospice in facilities.
Yeah, I think and nursing homes have a really difficult time. The COVID epidemic put them in a bind. There's staffing issues, and same thing with all healthcare facilities and organizations, including ours. But when you have an extra set of eyes in there, so if you're a patient in a nursing home situation and you got someone going in there, so our once a week as a nurse, sometimes our CNAs go in there. So it is that extra support, because what we're going to do is we're going to call you. And we're going to work with that facility. The facility's our partner, so we want to partner with them. But having one more set of eyes, I think, in those type of situations is invaluable. I'll be honest with you, having that and knowing that, especially if you're out of state. I mean, I can't tell you how many patients we take care of, and their daughter is in California or Wisconsin. They don't know. They don't know what's going on, and maybe they come home at Christmas. And that's when amazingly enough, that's when we get a lot of referrals.
I know. It's January. We get so many referrals.
We get so many referrals because everybody comes home at Christmas and they haven't seen their mom in a year. And they go, what has happened in the last year? And then we get these calls like, Mama's lost 15 pounds, 20 pounds. And we get these referrals. And so that's a lot of times we get to see. But I think that makes that daughter or that son or whoever's in another state and more comfortable because they know they can't be there. And I'm sure they feel very anxious about that, but having someone else that will call them like, hey, let me give you an update. Let me just give you an update. And I'll be honest with you, the nursing homes are so busy, they don't necessarily have the time. And luckily for our program with hospice and palliative care, we can make sure that we can sit down and make that phone call. Let me just give you an update. This is going on with your mom today. We're gonna make some changes on some medications. She's sleeping a little bit more. And just kind of keep them informed, even if it's not anything big going on. It's just nice to know you're going to get that phone call.
So here's a question. I think somebody called me yesterday. When? Like, how do I know when to make the call?
Yeah. I think that's a tough decision. Dementia is really a very tough disease. I mean, from a physician standpoint, it is a tough diagnosis and to make what we call a prognosis. And I'll be honest with you, physicians are not really good about prognosticating. It's not something, and I used to teach it a lot. But in medical school, it's not something we learn about, when somebody's going to die. And I'll be honest with you, we're not thinking about dying. If I'm the family doctor,
you're thinking about living. Right?
I'm going to keep you alive. And if you're the oncologist or the nephrologist, your goal is really to keep people alive. So the mindset is not about, dying. It's about living.
Okay.
And I think that's a great thing. I think that's
fair.
a great thing. I want my doctor to be thinking about me living, but at some point you do have to flip a switch and start thinking about, all right, what is the best thing for this patient? And maybe hospice and a prognosis and saying when it is. And for dementia patients, it's pretty regulated in a lot of ways, but a lot of it just comes around, what their speech is. How many words can they speak? Are they bedbound now? Are they having more infections, UTIs, pneumonias, aspirating food, not going down well, and now they're getting food in their lungs and causing an aspiration pneumonitis. start seeing things declining. They're sleeping more. And so when you start seeing what I call this trajectory of declining, losing functional status, not walking as far, then I think at that point a little light needs to go on, not only on the physician's head, but anybody, the nursing home or anybody thinking like, okay, we're starting to see this decline. And I think it's always, at that point, you can say, well, maybe if it's something you're interested in, make a phone call to hospice, and they'll come out and evaluate. And they'll tell you, and they'll do a formal evaluation. They'll call the physician, a physician who's really good about prognosticating, and say, well, do you think they're ready for hospice? Meaning, are they eligible? And there's rules, Medicare, there's all kinds of insurance rules. And so you have to meet these thresholds to kind of get a patient in. And if not, that's fine too. You have a resource, right?
Yes.
You have this resource that you can turn to. And then a lot of times what our hospice will do, we'll call our palliative care program. Now, do we have all the resources in our palliative care program like hospice, we do
No.
have 24/7, you can call us, but we have about as many patients a lot of times in hospice with like 10 of us. Hospice has 400 people, 400 people to take care of. So it's a smaller program, but it is a program still that we can go in and educate that family. We can go in and be available 24/7. You call us, you're going to talk to a doctor or a nurse practitioner, and they're going to help guide you through whatever's going on. And I think, and I'll give you a story that I just last week attended an Alzheimer's support group, and it was in a memory care unit. And this gentleman has been coming to this memory care unit, Alzheimer's support, for years, even though his wife has left and is now in a nursing home.
Okay.
But he felt like it was so important to have that relationship. And what he told me was, hospice helped him, and I don't know what hospice this was. We didn't go into that. He said, he was concerned that, maybe his wife should have hospice at this point, and so hospice came in, and they really evaluated and found out, well, not really ready at this time. But they wrote this script down for him. And he says, and she was very violent at that time. Mm-hmm. She was cutting him and doing things, and they wrote, when you go to the emergency room, this is exactly what you need to say. And wrote the words verbatim, what to do. And it wasn't 24 hours later she got that way. And he showed up at the emergency room and took his script and got her admitted to a Jerry psych unit. And actually called the hospice lady who left her number, even though he was not on hospice or she was not on hospice, but called her, and she said, yes, take that script. This is what you need to say to make sure they get the attention that your wife needs. And so hospice helped this gentleman.
Although he was not on hospice.
No, it's not on hospice.
Yes.
So, and I think hospice organizations in general that way, they're there to help, whether you're technically their patient or however they can help. And so I think that was a great story, and he was so appreciative. Like, I didn't know what to say. And he'd been there several other times and didn't know how to put it into words. Yeah.
So what I hear you say earlier on when talking to your doctor or even looking at your loved one is advocating for yourself.
Sure.
Because sometimes, we have a belief that our doctors know everything or recognizes everything. So being able to advocate for yourself, and you can actually make the phone call to hospice. You don't need a referral.
You don't need a referral, and I wouldn't wait. If you feel like hospice is something that could be helpful for you, then go ahead and make the phone call. Doesn't cost anything. It's no harm, no foul, and actually it puts that hospice, put your loved one on the radar of that hospice, and they'll kind of a lot of times call in and check on you, call you every couple of months. How's it going? And if they hear something like, oh, well, Mama's not eating as much. Oh, well, let us come back out, and we're going to reevaluate you again. And so it kind of gets on the radar when you make that decision. It's, like I said, no harm and no foul. But if you kind of wait on your physicians, we got multiple studies. Physicians, a lot of times, are the biggest barrier to hospice, whether it's dementia or any other disease. And the reason being is, and I was in family practice for years, I had a patient every 15 minutes. Once you get to talking about life and death situations, it's a long and difficult conversation. And luckily for me, when I go visit someone, I do a lot of home visits, I'm going to be there for 2 hours. That's unheard of. And the reason I love my job is I can spend 2 hours.
Yes.
I get the ability to spend 2 hours because we're going to talk about life and death situations. We're going to talk about training, how to get you out of bed or pivot and do things like that. But physicians, and then I think physicians are uncomfortable with death too, right? Just like everyone else. And so, they love to say, oh, we're going to keep the chemo going, right? That's an easy sell because everybody, yay, chemo. But when you talk about death, it's not, yay, I love you, you're my doctor. It's, you may not be the hero anymore when you
Yes.
mention the word hospice. And so physicians a lot of times just don't want to get into that conversation. Not that they don't want to. A couple things. They're not trained. And there's specific training. And I ran a fellowship for years, a hospice and palliative medicine fellowship. And probably the number one thing we do in our fellowships, and I train the fellows at UMS now, is how to communicate bad news, how to empathetically have these conversations so that we don't walk away, the families feeling like, oh, that's negative Nelly. They're just negative. And so many times I would get a consult in the hospital from a physician who'd been trying to talk to this family, and they just didn't understand. And, we would go in and we would have a kind of a revelation, and they would get it, and the doctor would say, well, what did I do wrong? And I'm like, you just need to spend a week with us, because,
Yes.
it is about learning how to have these talks and learning how to communicate. And physicians are not always great communicators. Some are great,
Some
just like
are.
everywhere
Yes,
else. Some are
yes.
great communicators and some are not. But when you talk about life and death, it is vital that you be a good communicator, but also communicate empathetically. It's not like just going in, oh, you're dying. It is working through a process, and we have a very specific process to help families and caregivers understand, like, they are dying.
They are.
And I don't have to say it. They start telling me, oh, I ask them a question, what's going on? And how was last Christmas? And it's Christmas now. Well, last Christmas, Mom was up walking around. This Christmas, we hadn't got her out of the bed in 2 weeks. And she just, she's really not hungry.
Yeah,
she loves turkey. She will not eat the turkey. I said, well, that's not great. Well, tell me some more about what's going on. Well, yeah, now she's, waking up and they're not, traveling. We have to lock the doors. So that wasn't happening last Christmas. Right? And so then they start telling this story. And as we get that story, I think the light starts going on in their head, like, oh, yeah, it is a lot different. Like, and you don't notice it like a week to week, because as a caregiver, you're so focused.
You're in the forest.
Yeah, you're in the
You don't
forest and
see
you
any
can't see it. But
trees.
if you could just step up and get above the trees a little bit, you see, oh, Mama is going down here. Yeah, Mama has lost 30 pounds in the last 6 months. I just haven't paid attention to it because I'm so busy focusing on the day-to-day, the big picture. And so having that conversation is a critical part of that. And that's, like I said, it's not a short conversation. It's not a 15-minute visit, right?
It is not. And last week I was talking to your wife, and
Uh-huh.
we were talking about some programming and some things that maybe we could do. And I was like, you just can't teach, though, a lot of people empathy and compassion. And that's what makes people, and I always say, if people work for hospice, they are special people. Things you can't teach. So it's not for everybody.
I tell you, and I never, especially my nurses and social workers, they come in there and they've worked in the hospital, but when you're a hospice nurse or you're out in the field, right, it's 3 o'clock in the morning, there's no doctor there you can call. You can call, but there's not right there like you're in the hospital. Or if you're in the clinic, you always have someone. You have to go out there and solve problems. And I know a lot of my nurses will hire and they'll get into like, oh, I didn't know it was this way. But the ones that stay with us, oh my gosh, their hearts are, I know they can go somewhere else and make more money. Mm-hmm. But they don't work for money.
No.
They work for their mission. They work for their passion. Mm-hmm. They work for, and the same thing with my palliative care team. They work because it's a work that fulfills them that maybe they can't get fulfilled other ways. It becomes a part of their life. And I think the work that we get to do, and especially as a physician, I feel that way. I get to not only get a paycheck, but I get a reward. I get these rewards that, and I'll be honest with you, I didn't get it always in family practice. I mean, I was seeing 40 patients a day, and I was so focused on this. And I don't, now I get to know these patients, and we talk about their lives and their kids and their wishes and their goals, because I'm there for 2 hours, not for 15. And we get to focus, and I get to know that person as a person, not as a patient. And you're more than your diagnosis, right? You're more than that. And so this field, whether you're a nurse or a physician or a CNA or a bereavement specialist, whatever, I think that's how they feel. It's a part of their mission. And another thing I'd love to talk about is hospice is the bereavement program, which when I say Cadillac program, hospice is the Cadillac program. Hospice offers bereavement for patients 13 months after they're died. Mm-hmm. So if you're a patient of hospice, you get this free bereavement care. It doesn't cost you anything. And quite honestly, for Arkansas Hospice, where I work for, we give it to anybody, whether you're a patient or not. Mm-hmm. So if you're not a patient and you want bereavement, it's called community bereavement, we'll do that. But I think that service, now think about this, anywhere in healthcare, if you're a hospital, the commitment to that patient dies
When they
either the
first-
patient dies or leaves the hospital, almost, right? The commitment dies. In hospice, the commitment goes on to the caregiver or the bereaved or whoever that is for at least 13 months afterwards with support groups. And so I think that's another very unique thing about hospice, to have this bereavement, and you have pre-bereavement, right? You have this,
Pre-grief,
these people,
yeah.
when you see about dementia, right, there's two losses, right? Right, and that's what I always say. It's almost
It's two. It is
two deaths.
It's two deaths.
It's the death of the memory in a relationship a lot of times because we can't talk about things and we're not communicating. And then there's the physical death. In cancer, most of the time you're right up to the couple weeks, maybe
You
you're
can
talking,
still
and we're talking about times and heart failure and all the other diseases. But bereavement's two deaths. So I think specifically for dementia patients, bereavement, you start to bereave. I don't have mama. We can't talk like we used to do about
She's not the
things.
same.
It's not the same.
She's not my mother.
Not
I've heard
right.
that.
Not the
This
minute.
is not my mother.
And the behavior is like this gentleman I talked to, his wife cut him, right? She was violent towards him, and like that, how much that would have hurt. I can imagine my wife, doing something. Well, yeah, she probably would.
We're talking about Sheila right now.
My wife, she probably would. She probably would.
But it's
No,
some
I'm just
other
kidding.
stuff she wouldn't do to you.
No, that's right. But so I think that's one of the great things about hospice. They have that bereavement component that you're not going to have in any other organization. That's a requirement for them to have that. So I think that's really important.
So as we end our conversation, if there was one thing you would tell our listeners out there in podcast land, when it comes to palliative care and hospice, what would you recommend to them?
Well, I'd say don't be fearful. I think don't be fearful of either of those, palliative care or hospice. This program, both of these are there to help. They're not going to shorten someone's life. I mean, that's just not going to happen. It's not their goal to do that. There's no way their goal. Even, unfortunately, I've had patients ask me, "Doctor, when are you going to give me the shot?" I'm like, that's illegal. That's unethical, and I would go to prison, and I don't want to go to prison. So we're not going to give you the shot. But there's still this. So, reach out. I know, especially if you have dementia, you need help. Help is nobody that I know that's a caregiver doesn't need some type of help. Sometimes it's bigger needs than others, but palliative care and hospice are a program that can get you help that you may not know out there, and maybe you didn't know you needed. And that's what I hear. The biggest one regret, and we get surveys back all the time in hospice. We get these surveys back. It's required. And the biggest thing they write in the survey, I wish I would have done this sooner. And that is the thing. The average time on the median length of stay on hospice is 17 days. Now you think about that, 17 days, not very long. Jimmy Carter recently, he's on now for a year. He's over a year right now. His wife had dementia, but she only stayed on that for like a couple of days. And I wrote something about this, about the two different Carter experiences, the Jimmy experience and the Rosalind experience. And I don't know why Rosalind did not get on hospice earlier. She had dementia, but that is the number one regret, because even if you're on a month earlier than you expected, not just the last 2 weeks, it's a month that you maybe have some more quality time. The patient obviously will have more quality time, but that month could be like an eternity, right? When you're not sleeping and things are going on, and knowing you can have that help, and everybody wants help, just not everybody knows how to reach out to get that help.
Don't know the help that's out there, and they don't know.
Right.
Yeah. So I want to thank you for taking time out of your busy schedule.
Sure.
You're such a busy man, but this is a much needed resource that people should not be afraid of and should know about. So that's why this is like the difficult conversation. So thank you again for saving my life that day, because that's why I'm here. And thank you for all the work you do. Like, so much respect for what you and Arkansas Hospice does. Like, I cannot, how many families I hear just rave about how hospice changed their experience. So thank you for
Thank you
sharing
for
today.
letting me come here and speak at some of your regional events. I love to do it. It's a passion of mine to educate folks and to let them know, there is help for you. And you give me that opportunity, that platform to do that. So I thank you.
Thank you, Dr. Bell.
All right, thanks.
Thank you, Dr. Brian Bell, for sharing your perspective of hospice and the benefits it can provide to many families. Please subscribe, review, and share this podcast. Thank you to Elder Independence for underwriting. I did not sign up for this.